everybody, to the prosecutor's office, and we're very excited today to present information that every prosecutor, frankly every citizen, needs to know about substance use disorder. You know, it's funny, substance use disorder is an actual medical term, it's an actual medical field, it's a scientific field, and it's also a fertile field for ideology. That is, people who don't know anything about the science or anything about the research nevertheless come armed into the discussion with their opinions about what we should do, what works, what doesn't work. And so I thought that acknowledging that most of the policy within the criminal sentencing laws and the RCWs, most of that was informed by politics and ideology, not so much by the science and the research. I thought, well, it may be 30 years too late, but let's bring in the science, let's bring in the research, let's ask them, what is it, substance use disorder? What works, what doesn't work, what are the myths, what do we need to know as prosecutors as we go forward? So we're very, very fortunate to have Caleb Banta-Green from the University of Washington. He is a nationally recognized expert in this field, and he's come to spend lunch with us. So thank you very much.
Great.
It's all yours.
Thank you very much. Thank you, great to be here, and that marriage of science and politics I'll share with you. In addition to my various jobs at the University of Washington, in 2012 I was the senior science advisor in the White House Drug Policy Office. So I got to see up front the clash of these two very different worlds and how science and policy happens. So I'll share with you, actually, at the time our drug czar at the time was Gil Kurlikowski, and I asked him how national policy got made, and he said, well, you either spend months in writing up white papers and vetting them and getting them through the Domestic Policy Council, and then we release them, or I just say it. I'm like, oh, well, let's have a conversation. So that seemed like an easier route to policy that I often tried, I freely admit. And we also worked on presidential drug strategies. So today I'm going to try to cover a lot around drugs, addiction, and recovery. Very importantly, I'm going to talk a little bit about a couple of medications in terms of treatment medications. So it's important that you know that I don't take funding from pharmaceutical companies and have no plans to do so. My funding right now to share with you comes federally from the Substance Abuse Mental Health Services Administration through the state. Some of my funding, and a lot of that is for technical assistance that I'm providing. You might have heard of these large multi-billion-dollar federal grants that are coming out around opioids and developing opioid treatment networks. I provide the technical assistance to those opioid treatment networks in Washington state. Sort of how to build those and how to create those and create these networks, which if we have time we can talk some about. So we have a real continuum of care, and there really is no wrong door, and every access point is available to folks. I also have a bit of funding currently from the National Institute on Drug Abuse, and importantly I've had funding from them in the past as well, so know that I've had funding from that group. And I'm going to talk about a new research project at the end of today that is funded by the Paul G. Allen Family Foundation, Premera, Washington Healthcare Authority, and from Seattle Foundation, so you should know about those funding sources as well. So what I'm going to try to cover, and we could spend many days on this, is why do people take drugs? What is addiction or use disorder? Why are we using this new language? What factors increase the risk of use disorders? Do people really not want treatment, like we often hear? And then particularly new approaches being used locally to address opioid use disorder in particular. So, as we talked about, there's a lot of different substances, alcohol being the predominant one that leads to use disorder and health consequences and criminal consequences as well. My expertise is more on the opioid, heroin, and methamphetamine side, so I'll talk more about that, but happy to talk more generally. Before I dive into this, I guess I want to just ask if there are any urgent, outstanding questions people have always wanted to know about addiction or drugs that they want to make sure that I hit upon. Well, think about that. Maybe it'll come to you. Okay, great. So I do want to ask you a question that you need to answer out loud with your words, and that question is, what are the reasons that you think about just why people just take drugs and alcohol? What are some of those reasons?
Makes them feel good.
Feel good.
Cope.
Coping.
Numbing other pains and issues that are difficult to face.
Numbing pains, things that are hard to face, yeah. Other things?
Physical need.
Physical need, yep. So I think, there's a lot of different reasons, and I'll just talk about a few of them. We certainly talk about sort of the social component, the peer component. There's just a lot of use, and we also know that the earlier people use, the more likely they are to develop addiction, adolescents in particular, with their developing brain, so that social and peer influence and norms are really important. You touched on this, but the mental components, medical, emotional, and I don't pretend those things are different. Anxiety, depression, pain, ADHD, among many other things. And then this idea about feeling good or not feeling bad, which are kind of two sides of the same coin. Just sort of, some people just sensation seeking, wanting a high, wanting to just feel really good. But a lot of people, I think it's really the flip. And I think where it can really be reinforcing is to not feel bad or to numb the pain. I think the challenging thing is that it really becomes a coping mechanism so that people don't have to deal with those negative moods. And I'm probably going to talk about it later if I know myself, but a lot of this can also be, some of that can be learned behavior in terms of watching parents use substances to avoid dealing with emotional pain. And I think one of the most classic things I think about all the time is to say, it's not a neutral statement for a parent to say in front of their kid, I need a beer to relax. Hear that all the time. You see it on Facebook all the time, people talking about that. And it's not neutral. That's a really powerful message that's getting conveyed to other people in the home. So, and for many reasons that are not necessarily overt, clear, or purposeful, it's never seen. No one says, oh, this is the first step to a pathway of addiction. No one starts using a substance thinking that they're going to end up addicted. Just no one has that approach to this. And so I think acknowledging, yes, a person makes a behavioral choice to start, but as I'll talk about and hopefully you'll learn, is that it is the rare instance where a person can simply make a choice to stop once they're in full-blown substance use disorder. And that's really important to understand. So what are substance use disorders? And I decided rather than starting from scratch, there was some pretty good language on the International Institute's on Drug Abuse webpage, and they're on there. You can refer to them. Here's the link. But I think these points are really important, and I just want to share them with you and answer any questions. So a lot of people mistakenly think that those who use drugs simply lack moral principles or willpower, and they could stop simply by choosing so. And as we're going to talk about, that's not the case. It is a complex disease. And quitting usually takes more than just good intentions or strong will. The challenge is to Dan's point, everybody's an expert on addiction because everybody's seen it in their life. But the challenge is that they actually don't understand the science, and they often generalize from what did or didn't work for Aunt Sally to everybody else. And we don't do that with other medical conditions, but for some reason we do it with addiction, because it seems like this simple behavior thing. It seems like a matter of will and choice. So what's important to understand is that drugs and alcohol do biochemical changes to the brain. There are changes to our neurotransmitter system that I'll show you in a minute that make quitting very hard, even for those who are incredibly motivated. They're incredibly motivated and they just can't do it, and there's reasons for that. The good news is we have research. We're learning a lot more about how the brain works, and we found treatments that can help people recover from drug addiction and lead really productive lives. So there is good news in all of this. It's not simple. It's not a Band-Aid. It is a lot of work, and it's a lifetime of work, but it is doable, and I think that's kind of really the take-home message. So it's a chronic disease, and as you've probably heard, it's characterized by drug seeking that is compulsive or difficult to stop despite harmful consequences. That's a mouthful. It means a lot, though. So part of the definition of substance use disorder or addiction is you keep using even though it's making you do bad things. The corollary of that is more bad consequences isn't going to fix it. That's the definition of the condition. And yet we keep trying to make things worse, or have a person hit rock bottom, or incarcerate them, and they'll see the light. Like, making things worse doesn't make things better. So the initial decision might be voluntary, but that repeated drug use really, really challenges the addicted person's ability around self-control, and it interferes with the ability to resist using these drugs. And it can be really persistent, if not lifelong, for people, these biochemical changes. And it's why we call it a relapsing condition. So people in recovery are at increased risk for returning to drug use even after years of not taking a drug. So specifically, I've done several research projects with people releasing from prison and community corrections offices in South King County. These are folks who've been in for years, and they talk about craving heroin every single day they were in prison. The relapse rate for opioid use disorder is 75% within 3 months. 75% of people releasing from prison who have opioid use disorder relapse. Not a single one of them plans to. None of them plan to. And I think the risk of it is very low, and yet the vast majority do. So they need some help. They need some support in that transition. So what's really important to understand is that it's really common for people to relapse. And relapse doesn't mean that treatment isn't working and that you aren't learning from it. We all relapse. I relapsed eating a giant chocolate chip cookie yesterday. And I don't mean that in a light way. Like I made a willful decision, I'm really going to watch my sweets and blah, 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 blah. And yet I had this compulsive need to eat this cookie. And that's a real thing. And that is on the continuum. I mean, what we all experience with food is all on the same continuum as with other substances as well. So that's a real issue, is that relapse happens. And it doesn't mean that I'm going to eat a cookie today, because I'm not. I'm going to do much better today. And with other chronic health conditions, treatment should be ongoing and should be adjusted based on how the patient responds. What does that mean for your work? It's not one size fits all at all. So you take 10 people in the same life situation, it looks like, they don't all need the same thing. And let's say they're on a pathway towards recovery and they're in treatment and it's a year later, they still don't need the same thing. And they may well not need what they needed a year ago or 6 months ago or a month ago. People's needs change. Their neurochemistry can change and adapt. There's social circumstances, their psychological reference points, their mental health, their physical health. All of those things change and they'll impact what treatments are going to work for folks. So the treatment plans often need to be reviewed and modified to fit people's changing needs. That's really important. So most drugs affect the brain's reward circuit and causing euphoria as well as flooding it with the chemical messenger dopamine. It makes you feel really good. And with repeated use over time, you literally get this hijacking of the brain, as the head of NIDA, Nora Volkoff, who's a neuroscientist, talks about this. You literally get a hijacking of the brain, meaning that what's important in your life is no longer connection, love, food, water, all of those things. It's that drug. And that's not a choice. This is literally a biochemical change in priorities in your life. I'm not going to make a choice to stop caring for my kid. That's not a choice to go seek heroin instead of taking care of my kid. It's a literal physiological change in priorities, and it's not purposeful. So a properly functioning reward system motivates a person to repeat behaviors they need to thrive. Good things like water and connection with other human beings and taking care of themselves and such. But these surges of dopamine in these reward circuits, they cause the reinforcement of pleasurable. They feel good, but they're unhealthy. They feel good, but they're unhealthy behaviors. And they get people to repeat that behavior over and over and over again. It does make sense. These things make sense biochemically. From the outside, they look completely counterproductive and insane, and why doesn't this person make a better choice? On the inside of the brain, what's happening makes sense if you can understand it and sort of deconstruct it. It's not simple, but it is understandable. Questions so far on all of this, or comments, please?
Is there such a thing as predisposition to addiction, meaning one person can have these dopamine floods either quicker in time or higher in effect than others?
I'm going to come to that. Yes is the answer is yes, and I'm going to explain it more in just a sec. Yeah. So the question is there predisposition to addiction, and as part of that, is there predisposition to responding differently to dopamine or other neurochemicals? The answer is yes. There's your picture. Thank you for the transition. I did not set them up. So this is just an example actually by the current head of NIDA, Nora Volkoff. This is actually an old brain scan. And this is showing sort of the quote normal healthy brain. And the lit up area here in red is dopamine. And what happens is you see is that with among a person who had long-term methamphetamine use who had stopped for a month, so they had a month of absence or no use, you're seeing that their ability to respond to dopamine is grossly diminished. So it has serious impacts on that person's brain functioning. And this is now looking 14 months, almost a year later, and we have a pretty much normal return to functioning. Not entirely, but pretty normal return to function. And we'll talk more about this and the implications for that in a minute, but the short answer is that methamphetamine in particular is very neurotoxic. It's very hard on the brain in the dopamine system, and that really impacts cognitive ability as well, the ability to learn. So taking a person who has methamphetamine use disorder and putting them in drug education classes, you might as well just be flushing your money. The idea is going to be much more helpful for them is likely to be some sort of therapy or counseling or environment that's very social, that they can engage in, but not have to be doing these sort of high-level cognitive tasks and expecting people to retain that. So we can have this really good intended intervention that is really just a waste at that point. The idea, though, is that people can respond to that eventually. And the challenge is how do we set up a system that cares for people with serious health condition for a long enough period of time till they can get to a recovery of their status. And it might take 12 or 18 months. And we're lucky if we get things like care navigation for 6 months or a month. So it is rare. It's actually the Parent-Child Assistance Program for pregnant and parenting women with substance use disorder. That program actually lasts 3 years, which is a pretty reasonable period of time. And a lot of that is developmentally around the child, but also around that mother's recovery from substance use disorder. But that's really true for everybody. We need much longer periods of time where we're providing supports. Providing supports and acknowledging that during that time, the vast majority of people are going to have relapses. And again, further punishment is not going to speed their way to recovery by definition. So why do some people become addicted and others don't? There's not one thing. There's not just one thing. So it's a combination of things. Biology and genes, we think genetics is about 50% of the predisposition. There's a really strong genetic component. And I'm a doctor of public health, not of medicine. So I can't tell you how much that's about how much dopamine comes out or how you respond to it or how it feels. But there are really strong biological and genetic components that would be at that cellular level. Really importantly is the environment. Trauma, learned coping mechanisms, and you probably have all heard this a million times at this point, I hope you have, around trauma, and this whole idea about cumulative adverse childhood events, right? The more bad things that happen to a child as they're growing up, the greater their increased likelihood of having mental health or substance use disorder problems. And then development, sort of how these things come together. These genetic and environmental factors, they interact with each other, and particularly there's that really important element around adolescence. And I'll share with you sort of my area around opioid use disorder. The peak age of first misusing, when you're most likely to misuse a pharmaceutical opiate, is 14 and 15. It's very young. And that, of course, is based on an environment and learned behaviors that were happening probably 5 or 10 years before then. And so when I think about what is prevention really meaningfully going to look like for folks, it really is really early on how we think about how do we model and teach and think about and talk about how we deal with physical and emotional stress. So pain is normal, right? We're increasingly creating materials around pain that say pain is normal. If you sprain your ankle or you break your leg, you're going to have pain. That is normal. And if you have pain, it's likely to go away in a week or two. Opioids are usually not the substances that you need. And if you do need them, you probably do not need more than a couple of days worth of those medications. That's really important to just change that dialogue, in part so the providers don't feel the need to prescribe that, but also the customers, right? The patients think, oh, I need these things. I want to leave this medical visit with this, and if I don't, I'm being denied good care. So we need to sort of have that conversation really early on about how we deal with physical and emotional stress. To me, that's really what primary prevention is about.
You said that if it's happening in 14 and 15, they'll go use their sort of precursor when there are 4 or 5 years. So what would be they doing? What types of things would they be doing at 9 and 10?
Yeah.
Which would lead to that.
Yeah, I think the real things we talk about is teaching people that stress, emotional and physical stress are normal, and teaching them good coping tools. And people ask like what I try to do as a parent with my 15 and 19-year-olds is I'm trying to build up a giant toolkit of stress coping materials. I don't call it that, but we talk about, hey, if you're feeling stressed out, go for a run, listen to music, talk to a friend. All of those things are great stress coping things, as opposed to drinking or going and hiding and being isolated or those types of things. So it's kind of simplistic in some ways, and I want to also acknowledge that it is simplistic. And for me to say that in my context, where I have a lot of privilege, is really important to recognize. A person who is homeless or dealing with a family history of trauma or is in emotional or financial crisis, that's a much harder thing to do, and I want to acknowledge that. But still, we can be teaching people how to try to identify, recognize the own stresses that they are feeling. It's literally like I need to identify the feelings, acknowledge them, talk about them, and have those conversations and build up that toolkit of sort of stress management tools. Does that make sense? I realize that sometimes it doesn't sound magical and maybe deeply satisfying, but it's true. and it really is asking parents in particular to really be mindful and thoughtful and purposeful about their own behaviors and their own words that they're using. And it's slowing down and being aware of those things and being thoughtful about them. And then as a society, also recognizing the incredible additional risk that's brought by being in trauma and in stressful environments, and that it's our job as a society to try to address those problems, right? So there's me dealing with my family, and there's me dealing with society. Hopefully we can, if we have the resources, do both of those things. Before I switch, and I want to move on to really talking explicitly about opioid use disorder, heroin addiction in particular, and some really amazing things that we're doing locally and we're starting to do more across the state. Any questions about sort of what is this addiction thing? How do we respond to it? What's helpful? What's not helpful? These are perfect questions so far, so I welcome more. Please.
Real quick, is there research that compares the efficacy of the traditional 12-step program versus more of a harm reduction program? I know that's sort of the range of options that people talk about.
So the question is about sort of how efficacious and how effective are 12-step programs versus sort of harm reduction programs, and let me sort of talk about that. I'm going to talk about that kind of at the end here in some ways, but I think what I would, the way I like to think about 12-step in particular, and it's very important, and I should say that I did my original training in a methadone maintenance clinic in '95 when there was a Kingdom just down the street, and we sent a lot of people to 12-step programs, and we forced some people to go to 12-step programs. The thing about 12-step is, my simple summary is, it works great for the people it works for. And the people it doesn't work for, it's not because they're failing treatment, it's because it's not helpful for them. And we should never be mandating that for folks. There's definitely not research that says 12-step has amazing outcomes and you should mandate everybody to these interventions. It can be helpful for some people and not other people. It's a great option to offer people, but there's definitely not science that says it's so effective that you should mandate it. And I'll talk more about what are some of the other components of treatment that have different levels of science. So that's a really important question. Okay. So this, sometimes I feel sort of silly, and I often joke that my job as a researcher is to document the obvious, but that's what I do sometimes. So despite what we may hear, see, and believe, most people with substance use disorders do not want to be using drugs and alcohol in a harmful way. That's obvious if you've ever actually worked with a person with substance use disorders or had a loved one. Like, they don't want to be in a situation. But if you haven't, and you're dealing with what feels like a hostile neighborhood and people coming through your neighborhood and all this kind of stuff, and it looks like somehow people are having fun and pulling one over on society, you may not believe this. You may think that this is volitional. People want to do this, they're having fun, they're having a good time. And you might feel that walking through Westlake Center and seeing young adults acting like they're having a great old time while they're high. I think it's important to remember those are young adults who always like to act like they're having a great time when they're in public. And it's not unique to their substance use. So I think that's important to bear in mind, is that people really are not having a great time on average. They really don't want to be using. And specifically, again, in terms of documenting the obvious, we did a statewide syringe exchange survey. So these are people who are injecting substances, almost entirely heroin and methamphetamine. We did this in 18 syringe exchanges around Washington State. You can see where those are. About 400 of those surveys were done in King County. It's actually being wrapped up this year's as well right now. So it was over 1,000 folks, and we asked people a pretty straightforward question: how interested are you in stopping or reducing your opioid use, your heroin or prescription pill use? And so the answer was 78% said they were very or somewhat interested in stopping or reducing their use, the vast majority. What's important within that is what question we asked. We didn't ask them, do you want treatment? That answer is almost always, it depends. And so we didn't want to ask this sort of abstract question that has all these other connotations about, well, I wasn't treated well there, or they won't let me in there anymore, or they kicked me out of there. I asked the behavioral question, do you want to stop or reduce your use? And the point is, the vast majority of people do, who are using opioids. And if we have time, I'll talk about methamphetamine, which is a little different. So most people want to stop or reduce their use. And then I'll show you in a minute what we ask them further, what treatments they want or what interventions they want. What's also important to understand, and we were talking about this earlier, is it is the rare person who uses a single substance. So this is among people at the syringe exchange. So we had about 1 in 8 said they only use stimulants, almost mostly methamphetamine, a little bit of cocaine, but these are mostly injectors. And about 1 in 8 said they only used opioids. So that's the minority. A quarter of people use essentially a single substance. Most common was over half of folks said heroin was their main drug and they also use stimulants. And then on the flip side, we had a proportion of people who said they use meth as their main drug and also opioids. So most people use multiple substances. That's statistically normal. That's the typical thing. And there's reasons for that. It has to do with biological things. It has to do about I don't want to be too sleepy, or I want to control the come down for this, or it's not safe for me to be asleep at night on the streets. There's reasons. This isn't just random. There's reasons that people are doing this. Just like perhaps some people in this room might have coffee in the morning and a glass of wine at night. It is not different. We're talking about the same phenomenons. We are all the same. So most people use multiple drugs. Many are homeless. Only about a third of folks at syringe exchange are housed. About a third are homeless, and about a third are housing insecure. And many can't engage in counseling. Kind of to the point was raised earlier around 12-step. One of the reasons it's counterproductive is a lot of people have a real history of trauma, or they have social anxiety. They're very fearful about being in public, generally talking with other people, and particularly talking about things they're incredibly feeling a great deal of shame about. That's not a surprise. I mean, how many of you would like to right now go talk about the thing you're most shameful, feeling most shame about with a room full of strangers? Not me. That's not what I would like to do right now. And yet somehow we think that is something that other folks should have to do. Some people find great benefit in that, but for other people it's really aversive and counterproductive and can actually trigger relapse. So we have the situation where most people want to stop using, most people are using multiple substances. We ask people, what service options would you want if they were easy to get? Really important, easy to get. Interestingly, and this is focused on people who are opioid users, number one was treatment medications, which is interesting, to me, hopeful, because that is by far the most effective intervention we have, and I'll talk more about those interventions. And within that, it was sort of split between methadone and buprenorphine, which I'll describe in a minute, and this newer medication, naltrexone, which I'll come back to. But really importantly, and we see this all the time, many people are interested in detox. It turned out statewide people were more interested in detox if they were in a place that didn't have good access to medications. If the main option for something substantial was detox and not medications, they were interested in detox. A lot of interest, very importantly, one-on-one counseling for addiction, outpatient treatment, mental health care medications, inpatient. Actually, I didn't have 12-step up there as kind of a treatment intervention. I do think it's not the same thing, but these often go hand in hand. A lot of people who've done well in one-on-one counseling for addiction are often the same folks who are also interested in 12-step or other social support groups. I just want to explain these medications for opioid use disorder really quickly to folks. And so here's this brochure, and on the back side we first talk about what is opioid use disorder. And we try to use really basic language, and we talk about it's a long-term medical condition. People with the condition become physically dependent on opioids and have brain changes that impact their thinking and relationships. What the heck am I talking about? What I'm telling you is that opioid use disorder is three things. You have to have three things. Physical dependence, and that happens over time. If everybody in this room takes opioids 4 times a day for a month, we're all physically dependent. That's just a physiological thing that happens. And when you're physically dependent, if you stop taking immediately, you'll go into withdrawal. All of us, everybody in the room, that's just a biological thing that happens. And withdrawal, to be clear, as I've heard it described to me many, many, many times, is excruciating. It's not just uncomfortable. It's like the worst flu you've ever had, or the worst rotavirus, or as people often will say, when you're so sick that it actually feels good to sleep on the bathroom tile floor, it's that sick. You feel that bad. You feel that close to death. So it's really, really aversive. People don't want to feel that way. So they're avoiding that by continuing to use substances. They're trying to avoid that. So the physical part is very important. We talked a little bit about the psychological part, or the thinking part, which involves compulsive use, craving, this change in salience, or what's important for folks, this priority becomes the most important thing is to use that substance, which of course is then going to impact your social functioning. I'm not going to be a great dad or teacher or parent or employee or any of those things if I've got this biological sort of addiction, this roller coaster of use, combined with this craving and fixation on substances. I'm not going to be able to function socially well. So substance use disorder generally is all three of those things. It involves physical dependence, thinking problems, and social problems. Why does that matter? You will find out. The punchline will come back. So, and opioid use disorder can come back if it's not treated properly. It relapses. You may need to try more than one type of treatment to find out what works best for you. Everybody is different. I might do well on brand X antidepressant, and my friend might do well on brand Y. We're just different. We're biologically different. So this is not a one-size-fits-all thing. So what can medications do for you with an opioid use disorder? Medications can help manage withdrawal and craving, reduce illicit opioid use, and 2 of the medications have been proven to reduce your chance of dying by at least 50%. When I talk with my physician colleagues, and my prescriber colleagues, they explain medications for opioid use disorder are some of the most impactful medications they have for any health condition they treat. And yet very few people fully understand that. And the corollary of all of this is that I'm going to talk about the different medications. 2 of them are opioids. They bind to opioid receptors and turn them all the way on or part way on. So they're opioids. You can be physically dependent on those medications, but you're not on this roller coaster. You're not using heroin or fentanyl pills or whatever 4 or 6 times a day. You're taking a medication once a day by mouth. Once a day I'm taking a pill or a film or something, and it just keeps me at a steady state. So you're off of this physiological roller coaster. And the point is you can be physically dependent on a medication and be in recovery. You can be out of the chaos. So I think about substance use disorder, that emphasis on disorder, the lack of order, the chaos. What I want people abstinent from is harm. I want them abstinent from chaos. I don't care if they're abstinent from a medication that's having far more benefit than harm, but there's a lot of confusion about that. There's a lot of confusion about those medications that somehow they are perpetuating addiction. They're not. A person is still physically dependent, but if that medication is having more benefit than harm, it's getting a person out of chaos, that's a net good. We want to support that. So the point of this flyer, and I won't go into it in full detail, is there are 3 medications. We describe each of the 3 medications. I'll describe them in a minute. They're quite different from each other. And they can also, some of them can be obtained in some care settings and not in others. So just to be really clear here, we have methadone, which people are probably pretty familiar with. I'm going to describe it more in a minute. But methadone has been around since 1971. It's a full opioid. The more you take, the more effect you get. It's used only in opioid treatment programs, which we typically think of as methadone clinics, which are highly regulated by a DEA. Your first 3 months of care, you have to take your medication in front of a nurse 6 days a week. There's nothing more structured than that. And yet I found that worked great for some of my clients when I was doing my training, because they were folks who'd been raised in chaos and they didn't have any structure in their life. So that external structure was really important. And for other people, it's completely counterproductive. Like, I can't get to my job and get my kid to school. That's not going to work. So another medication came around in 2002 called buprenorphine, which is a partial opioid. It sort of goes into that opioid receptor and turns on part way. It's a bit of a safer medication. You can't overdose on it by itself. You can if you combine it with other drugs and alcohol, but it's a safer medication, which is why it can be prescribed. You don't have to go to a clinic and have it administered or dispensed to you. You can go to a medical provider and have it prescribed to you. And so that's buprenorphine. And that's also, these are both once-a-day oral medications usually. And there's a newer medication you may have heard of called naltrexone. The long-acting injectable form is called Vivitrol. And it's a pure opiate blocker. And it's given by injection, and it lasts about a month. And as you'll see up here, a lot of interest in methadone and buprenorphine, less in naltrexone. I think a lot of that lack of interest in naltrexone was a lot of people weren't familiar with it. But what's really important, and I don't know if I have the article in here or not, is that buprenorphine and methadone both have been shown over and over and over and over again to reduce mortality by at least 50%. Naltrexone has been shown over and over again, it's newer, to not reduce mortality. While people are on it for a few weeks, it certainly is protective. But the challenge with naltrexone is that most people don't come back to keep getting that shot, and it doesn't provide benefit if they don't come back. And there's lots of different reasons they don't come back, but in the real world they don't. And because they don't come back, it doesn't have mortality benefit. It doesn't keep them safe. You're kind of punting the issue a few weeks down the line. And it matters because I'm doing a ton of technical assistance right now with Department of Corrections and with jails around the state. And there's an instinct to like, oh, medically enforced abstinence with a once-a-month shot sounds great. But the effectiveness data are mixed. They're good for reducing illicit opioid use, but the challenge is we don't have good data about long-term, how to keep people on, how to match them well to treatment, and so far it is not showing a mortality benefit. We're having a lot of conversations right now about, well, so what does that mean? Do we not recommend naltrexone? So I'm not a medical provider, I'm not recommending anything. I'm trying to give people enough information that they can pick something they're interested in and go talk to a medical provider about what's the best fit for them. I think one of the issues with these medications is that you can't get them all easily in the same setting, and people have different sort of preconceived notions. I think the big thing is whatever a person picks, even if they're all in and super excited about it, is to recognize that relapse happens and that this might not be the right treatment for you. Medications might not be the right treatment for you. the addiction medicine doctors who I work with uniformly say the majority of people are going to do best on these medications for at least a couple of years. That's sort of the general consensus. We don't have research that says this person's going to do best and they can be detoxed in 6 months. This person should stay on for 10 years. We don't know that. So it really is this idea that we have to stay in close contact with people as they're working through their recovery. Was there a question there? Yeah.
I'm just trying to put this together. So naltrexone, if you, for example, were administering that in a prison setting where you can make sure they got it on a regular basis, it would probably work very well there. But what you're saying is once they head out, it doesn't have a lasting effect.
That's right.
And so would it make sense then to transition to one of the other two, or train them on where they can get that once they get out?
So it's a great question. So the question is, if naltrexone works when you use it, couldn't you use it in prison or long-term incarceration, but we'll talk prison, 30 days plus, or longer than that, obviously, and then transition. So there's a couple of issues within that. The short answer is you could. The medium answer is some people don't feel right on it. A lot of people with opioid use disorder, when they take opioids, whether they're illegal or whether they are these medications, they say they feel normal. And some people will take naltrexone, which is an opioid blocker, and not feel normal. So they just won't feel right on it. So for some people who do like it, and there are many people who do like it and do well on it, but it's not the majority, they could do that. A particular issue, and I'm getting a little bit into the weeds, I apologize, is that because this is an opioid blocker, the timing's tricky. You can't have an opioid blocker in your system and then try to take an opioid medication. So that transition is actually kind of tricky. There's just that issue to deal with. But the big issue, and we're actually hoping to do some more training with our folks who are care navigators, is if you send a person anywhere out with naltrexone, as that medication slowly wears off around week 3, you need to really reach out to them and find out how they're doing, how they're feeling, how can we set you up for the next injection, and or if you don't feel right on it, how to prepare you safely for getting on these other medications. It's a really, really important transition period. And they're very vulnerable to relapse and to overdose.
If you're on methadone or buprenorphine and you were to use heroin, would you feel that additional effect?
So it's kind of complicated, and I don't fully understand all of it. But if you have very high tolerance with methadone and or buprenorphine on board, you generally are not going to feel much effect from the heroin because it's going to be those receptors are going to be occupied by these other opioids. So you can get an additive effect and can get an overdose, but it's harder because your tolerance is much higher. Yeah. Is there another question in the back?
Do any of them make you sick if you do try to use on top of them? I know there are some medications that will actually make people feel sick if they try to use on top of it.
Yeah, so the question is about, will these medications make you sick if you use on top of them? So a couple of things. No, the short answer is no. So for buprenorphine and methadone, the answer is no. If you're using heroin and all of a sudden you take naltrexone, that will put you in a withdrawal. So that would make a person feel very sick. I think what you're thinking about is probably antabuse for alcohol. We don't really have the same type of substance used in the same way for opioids. So it's a bit of a different set of tools that we have. Yeah. Okay.
Last question.
Please.
I've had this one actually for years.
Yeah.
With methadone, obviously, it says there's an opioid effect, which I hear as being, makes you high.
Yeah.
So how is the high from methadone different from the high from heroin, and why is it therefore better?
Yes, so really important. So if you look at this little diagram here, the issue is this blue line is methadone, and what this line means is the more you take, the more effect you get. You take not enough, and you feel withdrawal or craving. You take too much, and you can feel intoxicated and or sleepy. And if you take too much beyond that, you can overdose and die. So you have to get to the right dose for you. It has to be dosed very carefully to find that point. And not everybody can find that point. The other thing is these are also opioids, and so they can have opioid-related side effects. People can get headaches, they can get constipation. They may not feel good on these medications. I think what I haven't been clear about yet is there are a lot of options. And what I want to take a step back and say is that this brochure is really the idea is to use this in a shared decision-making process or a treatment decision-making process. So when I got hernia surgery, my surgeon described the hernia I had and what type of surgical options I had, and then I got to make the choice about my health care. In my 24 years of experience, that is atypical for a person with addiction. Because of their situation, socially, financially, geographically, they either have no choices or one choice. And so what I want to do is say, you have a life-threatening medical condition. You need to understand the medical condition. You You need to understand your treatment options, and then you get to choose your care, which again shouldn't sound revolutionary, but it really is for people with substance use disorder. And it's complicated because you've got different types of care and different settings and different insurance and all of that. But fundamentally is to recognize it's a healthcare condition and people need to understand it and have a voice in their care. And the more voice they have in their care, the more likely they're going to do well because they're bought into it.
The methadone regulations that require an observed dose 6 days a week, and I drive by the clinic on Airport Way often, and there's a big line of people. To me, it means like those people really can't do anything else all day except show up to get their observed dose. Can you get to the point where they give you some take-home methadone?
Yes, so a little bit further, and so methadone, the first 90 days, you have to take your dose observed 6 days a week. As you do well and get stabilized and are doing well in your recovery there, you can start getting take-homes. You can start going in every other day. You can eventually get a week take-home and so on. And in Seattle, actually, we just got a mobile methadone van that is in the U District and I believe Belltown as well, so that people can also not have to come to Capitol Hill or down to Soto. If you live north of the Ship Canal, for instance, or in Belltown, you can go there and save yourself a half hour or an hour or 2 hours, depending on your bus or driving, right? I mean, this is a terrible time to be having to cross town every day for your medication. So there are ways that it becomes more patient-friendly over time, for sure. Yeah.
So the answer is that you have to take more methadone to get the same high, or there are two different, or heroin has two different effects, and heroin gives you both effects, and methadone only gives you one effect.
So it's a great question. So I think part of that question is, can you get high on methadone? I mean, the short answer is yes, you can get high on methadone. It is a full opiate. You can definitely get high on it, for sure. That's why it has to be dosed very, very carefully. Buprenorphine doesn't have as much of a potential high, and particularly for people who are physically dependent on opioids, they rarely report feeling a high on it. There are challenges that, since I'm talking with folks in the criminal legal system, that are very important to understand is if a person's coming out of incarceration and hasn't used in weeks or months or years, we're very careful if we're going to use these medications to reintroduce them. So we're actually dealing with this right now. State Department of Corrections, I've been working with them for 8 years on this. Dr. Strick has really been driving a lot of this work. She's at Harborview. They're now starting to do buprenorphine inductions before release from prison. There's evidence from the state of Rhode Island that it has a significant impact in terms of reducing mortality. But there is a understandable question and confusion, and for some people a conflict about, wait, this person hasn't used in 3 years. You're gonna put them back on an opioid? Why in the world would you do that? They had this beautiful gift where they got abstinent. We gave them a gift of abstinence for 3 years, and you're gonna make them redependent on opioids. And I think that is an understandable confusion until you understand that opioid use disorder is making these changes in the brain that may well not have gone away, that the craving is still there, and that the risk of relapse is so high, and with that risk of relapse is the risk of overdose. So it's a long conversation with folks, and we do a much more detailed training than we're doing right now with those assessment folks and with those providers in the jails and prisons, and we're going to be doing a lot of that over the next year, just so you're aware of that. About how to make that much more a part of care, because it can seem counterintuitive to folks. And I think it's this idea where people say, well, they're not using opioids, why would we put them back on opioids? And the reason is that most people are going to relapse, and when they do, it's very dangerous. So rather than getting back onto that roller coaster, let's just get them back to that steady state. And for a lot of people, they'll just describe feeling normal. The right dose of those medications is when a person feels normal. And good medical providers will really carefully watch that dose. It's really, really important in staying in close contact with that person to make sure they're not taking too much or too little. That's an integral part of good medical care for these folks. Yeah.
I assume that I know the answer for the present, but is there any hope of having a medical test for dependence in the future?
A medical test for dependence.
Right, so that you could know what someone's likelihood to relapse is. Is there any chemical way you can measure that?
Not to my knowledge. People are certainly trying to look into that and trying to understand that, about which people are going to do well or not on opioids. But that we're not there yet. I think the bottom line is is trying to be really careful and make sure we're not having inappropriate initiation of opioids. Really trying to be thoughtful about that. You know, for minor dental procedures, the question I always ask somebody who's prescribed an opioid is ask the provider nicely, is this for my comfort and well-being, or is this for your convenience so I don't call you back over the weekend? You need to ask it more nicely than that. But really, what is the chance that I actually am going to need to use this? And do I really need 60, or can I take 2 home with me? Really to push and question that. And increasingly, people are doing that and being, sort of better self-advocates and better informed patients. Yeah. Okay, let me touch on a few more things. One other thing I'm really excited about, so in this context of most people don't want to use, and what I didn't share with you is most people also, 60% reported needing health care in the last year and not going to get it, generally because of, as a person with substance use disorder, how they were treated by the healthcare system. So they want care, and they're not going to the healthcare system because they're not treated well. So if you think about different front doors to care, what has been typical is, hey, welcome, over 3 appointments over the next 3 weeks, we can get you started on treatment medication. So first you're going to get an assessment from a counselor, then you're going to see a nurse, and then you're going to hit the real jackpot, and in 3 weeks you're going to see the prescriber and you'll get a prescription. Remember, this is a life-threatening condition. Every day on that medication, your chance of overdose plummets. And yet it is typical to say, we'll get it to you later. You have to earn it. You have to be motivated. You have to not use other drugs you're dependent on. That's the typical way we've been doing this. So instead, what we're saying now is, let's see if we can get you started on treatment medications right here and now, this afternoon. That's this new model that we're doing. So I actually kind of mentioned this, but I'll just describe it again. So this is this idea about how we're changing how we're treating opioid use disorder. And I apologize, this is a super busy slide, but let me explain it. So this is opioid treatment programs, what we think of as methadone clinics, sort of high needs clients with high requirements. Then we moved into kind of the medical world where we're able to use buprenorphine, usually primary care practices, and on average they're lower needs clients with lower requirements. One of the things we learned there is that providers are much more likely to prescribe to any patients, and within that to more patients if they have a nurse care manager. So that's how we staff this, right? Doctors are busy, they're expensive, a lot of them are pretty nervous about working with this population, and so a motivated trained nurse can really help liberate them in some ways and make them more willing to care for more folks. What we've started doing here locally, San Francisco and New York have been doing it off and on for 15 years, is what I call sort of a public health model, which is that we're getting high needs clients with low requirements. High needs clients with low requirements. And you can do this in different settings: public health clinics, emergency departments, syringe exchange, jail, prisons, drop-in centers. And here, we have this nurse care manager, but what we think is really important is this care navigator to help that person stick at the front end, stick around that program. They get that day, they get the prescription the first day, get them to come back the next day, get them to come back the next week, and so on. But ultimately, even though we want to create this sort of low barrier, easy to access point of care, we want to hook people up with long-term health care, either in an opioid treatment program or primary care, so they can address their very likely other health care issues and maybe their mental health issues. The reason this matters is, depending how you count, about 10 to 15% of opioid use disorder currently are getting care here, about 10 to 15% here. The vast majority aren't getting any care. So we're trying a new approach, which is, let's open the door. Let's take a different model here. Let's try to get people on medications first. Let's get them off of the roller coaster first, and then we can start dealing with other things. Too often what we're doing here is saying, get yourself off of the roller coaster. Once you're off of the roller coaster, then we're going to start taking care of you. Once you've shown you're motivated and you're going to be able to do all this. But by definition, that's not most people. Most people can't get off the roller coaster by themselves. So we're taking that new approach. I'm calling it medication first. I've called it a lot of other things. I'm going to call it medication first today. The idea behind it is that it's drop-in visits. It's a short time to medication start, usually the same day. Polysubstance use is allowed initially and ongoing. So you can use your alcohol and your methamphetamine and your marijuana. That's the majority of people are polysubstance users. So if you don't let people in who are polysubstance users, we're automatically saying we're not going to take care of most people. No counseling or support groups are mandated, but they're always offered. We're not going to mandate it. And I think this is a very fair analogy. If I have diabetes and I'm on insulin, my doctor doesn't take me off of my insulin if I stop going to my weight loss support groups. They don't do that. And yet we do that for people with addiction. And it's nonsensical. And then it's very important that we do regular urinalysis. We want to understand, if people are using buprenorphine and or what other things they're using. And we don't want to kick people out of treatment just because of that, but medically it's important to understand what drugs people are using. I need to know if a person's on buprenorphine and they're using methamphetamine and they're using Valium. I need to know that medically it's important because it increases overdose risk. It also indicates there's a lot of behavioral and practical reasons that people use stimulants and anti-anxiety medications. And they're frankly the same reasons that people in this room and people in our society use stimulants and anti-anxiety medications, right? And so we want to address those as sort of other behavioral health issues as well. And so I'm not going to go into detail here, but there are different models of care. You can make that a low barrier model that lasts for a week or a year. You can do this in different settings. What I'm really excited about is doing it in these community-based settings. And my work right now is really working with syringe exchanges. The idea that we're reaching out where people are. We already know what syringe exchanges most people don't want to be using, and most of those folks want to be using medication. So let's try it there, and we did, and I'll show you those results. And the idea is that I'm not looking for people who are all perfectly prepared and ready to go to care. I'm looking for the vast majority of people who would benefit right now. I'm going to skip that. What I'll mention, so this is coming out of the model that's at 4th and Blanchard, the downtown public health building, that is going to be expanding there and has already expanded across the county and increasingly around the state. So it's the same medication first idea. What folks happen here is they come to syringe exchange and they ask for, they heard about the program, or the clients or the staff and volunteers there say, hey, we have this program, are you interested in treatment medications today? A nurse does a medical assessment, see if they're actually appropriate. Do they have substance use disorder? Are they in the right medical state of withdrawal? You have to be in a bit of withdrawal to start on buprenorphine, which folks know who have substance use disorder. The nurse talks with the prescriber, and then the medication is actually dispensed at that on-site pharmacy. I like the joke that that public health building, which you should visit because it's very beautiful, is like the Disneyland, from my perspective, of public health buildings because everything's in one building. I'm actually working to launch this in 4 other places around the state, and nobody else has everything under one roof. And it really is wonderful to have everything under one roof because every transition is dangerous. Every time you send that person somewhere else, the chance of them wandering down the wrong, if the next person is offering the next opioid for cheaper and easier, they're going to take that one because they're in withdrawal. So we really want to get people seamlessly connected. So you were talking about long titles. Here's a long title. This is a research paper we published last month, Engaging an Unstably Housed Population with Low Barrier Buprenorphine Treatment at a Syringe Services Program, Lessons Learned from Seattle, Washington. And this is a bunch of folks from public health, behavioral health division, and a bunch of researchers and some great social workers and physicians who've been working on this program. This program launched in January 2017. I'm not going to go over this in a lot of detail. This is kind of the most exciting thing, and I think I'll just actually leave it here. What this graph is showing is the weeks of operation of the program, the first 20 weeks, and how many conversations there were about the program. So in week 0, the first week, there were about 27 conversations, and 2/3 of them were initiated by staff. By week 5, the majority of conversations are being initiated by clients. Word spreads. And pretty soon around here, people start lining up an hour or 2 early to get their treatment medications. So it's not that people don't want treatment. They want services on their terms. And this population, so we're pretty much full at 12 weeks. And so in that first year, there were about 146 patients. Less than a quarter of them were permanently housed. The vast majority of them used methamphetamine, opioids. A substantial minority used anti-anxiety medications. And a substantial majority kept using those other substances, except their illicit opioid use statistically and significantly declined. And if anything, it looks like we suppressed the mortality rate. You might think, oh, you're taking this really highly vulnerable, high-needs population. You're trying this sort of new radical thing out on them. I wonder if you're going to increase harm. What we found was that 2% of folks died. 3 out of the 146 died during the follow-up, so 2% per year. A study I did at Harborview with a very similar population, 6% per year are dying. These are people in average age in their mid-30s, and 6% are dying every year. So it's a really high acuity population, really high needs population. So I think I kind of want to wrap it up there. I'm not going to show you our complicated graphs, except to say that people came in and out of care. That's another thing, is we never gave up on people. So the takeaways were this high client demand, high needs populations. Most people are polysubstance users. And the other thing I forgot to say is 96% of the urinalysis tests showed buprenorphine. So they were taking their buprenorphine. really importantly. And the transitions were difficult. So I'm just going to say it auditorily. What we're doing now is I mentioned the private funding that I have now. We're replicating this in 4 locations around Washington State, and we're adding care navigation for 6 months. We're doing this at syringe exchanges in Tacoma, Walla Walla, Spokane, and we're hoping to open one soon on the very north end of Aurora, still in the city limits, where we can replicate this model, add care navigation, and then do formal research on it and really test and find out, does this work and how well does it work and for whom does it work? Also of great interest to me is, does it work and how do I make it work in these really diverse settings? And the reason for that, and the reason the Paul G. Allen Family Foundation was excited about this, is to try to make this a national model. I also want to then have a second phase of this work where we're working with other types of providers, not just syringe exchanges, but housing or homeless outreach programs, supportive housing programs, and so on, because as you know, some states don't have syringe exchanges. So I want to make a model that can work with other folks as well. So that's the work we're doing. That work is expanding in that building. It's also happening at Seattle Indian Health Board right over there. It's happening at Country Dock up on Capitol Hill. It's happening at Aurora Commons at 105th and Aurora. There's a lot of this work going on with neighbor care and other providers to do this low barrier. And the reason it matters, hopefully to you in part as well, is that we have some folks like hospitals and emergency departments and jails who are saying, well, I would get them started on buprenorphine, but I don't have anywhere to send them. And the point is, we do. We do have a place to send them. That's not an excuse to not get people started. So we're really excited about that. And I think this idea of care navigation is really important, and I'm hoping we can keep working on this and try this with other populations and other substances as well. So I think I'll wrap there. Any sort of last questions? Yeah?
How does the emergence of fentanyl change any of these equations?
So I was asked a couple years ago, what do we do when fentanyl hits? I'm like, well, what we should be doing now? There's no reason that should be changing the equation. So folks know that the opiate overdose death rate is unchanged for the last decade in Washington State. Even as prescription opiates have come and lessened, even as heroin came to mostly take its place, and even as fentanyl has emerged. So the overall issue is that the overdose death rate is been steady. So we have a lot more work to do to bend the curve. And the point is the vast majority of people are not getting into care. So for me, fentanyl is dangerous. It's bad. I think it's a sign of how serious opioid use disorder is, that people will keep using unknown drugs off of the street even knowing fentanyl is out there. That should tell you how serious opioid use disorder is, how strong that craving and compulsive use is. So what it does mean, though, also is from an emergency response perspective is very important, is people who live with, work with people who have opioid use disorder should know how to recognize an overdose and how to get and administer naloxone as the antidote. We have a webpage, stopoverdose.org, where you can learn how to do that. Also really importantly is we shouldn't be needlessly fearful of fentanyl. There's this idea about, oh, if you walk past a person who's used fentanyl, you're gonna die. What I get really worried about is this idea that I'm not gonna go into that room where a person had an overdose. This is what happened with HIV in the 80s. Oh my God, that person has the gay plague. I'm not gonna go in there. I'm not gonna go provide medical care, or I'm not gonna go as a medical examiner go into this space because I'm gonna catch this disease. That doesn't happen with HIV. It also doesn't happen with fentanyl either. There's confusion, it sounds very scary, but we need to keep this in perspective. Just touching fentanyl is not gonna cause an overdose. If a person has had an overdose and you think they had used fentanyl, you should call 911. You should know about Washington State's Good Samaritan law. You should administer naloxone, and you should give them, if they're not breathing, mouth-to-mouth resuscitation. You're not going to contract fentanyl and have an overdose by giving a person mouth-to-mouth resuscitation, and that's really important for folks to know. Mark?
Is there any hope of a medical-assisted treatment for meth, which I know the incidence of overdoses of meth and death rate related to meth is rising?
Yes. So I'll give you the short answer and I'll let you know we're working on it. So the question was, is there any hope of sort of medications for methamphetamine use disorder? Sort of this idea about a stimulant replacement medication, for instance, or other psychiatric medications. Those have been tested quite a bit for the last 15 years. And they don't work not nearly as well or consistently as opioid medications do. And it has to do with how big the dopamine hit is from methamphetamine. Nothing else is like it. Amphetamine or Adderall or Concerta doesn't give you the same hit, nor does Ritalin or methylphenidate. They just don't give you the same hit. For people who have ADHD and also use methamphetamine as medications may be helpful. There's interest in doing more research and studies on that, but we're not there yet. I think the issue with methamphetamine is We don't have a slam dunk of treatments as we do for opioid use disorder. It is a very pernicious substance. It's very hard on the brain and cognition and thinking. And so part of this is we need to engage people and figure out a way to kind of bubble wrap them for a year or two while we give them an opportunity and do a lot of trial and error. Try different types of counseling interventions. We have behavioral interventions called contingency management, where you encourage a person with really small little rewards, like a little gift card or something, to keep coming back for care. Some of these little behavioral things can actually increase treatment engagement and improve outcomes. So we don't have any slam dunks. So the idea is that we got to try a bunch of these things, but really find a way to sort of grab on and support and hold people through this process, acknowledge that relapse happens, and acknowledge also that methamphetamine is a really tough substance because people externalize and they act out and they have excited delirium. They're much more difficult to deal with than people who have opioids, because people with opioids get sedated and they're quiet. They're the opposite of methamphetamine. So there are other creative things to think about that I know our housing providers are thinking about as well, is how do we create places for people to safely blow off steam or tinker or whatever else without hurting other people or without destroying their rooms. So there's things that we're working on to start having some more harm reduction type interventions for methamphetamine to keep people sort of safe in the near term and figure out how to engage them in the long term. So I think we should wrap up there. I know we're at time. We covered a lot. Thank you for your great questions. I really appreciate it.